I am Dr. Derek Lee. It's my pleasure to introduce Dr. Michelle Welborn, who is a pediatric orthopedic surgeon at Shriners Hospital for Children in Portland. Welcome, Dr. Welborn.
It's nice to see you today, Dr. Lee.
Now, the first question I'd like to ask is, where was your first, or when did your interest in medicine first begin? And can you talk a little bit about your transition to becoming an orthopedic surgeon?
Yeah, I definitely had a little bit of a different path than others. Actually, my first interest came about because of a professor that had a heart attack in front of me when I was in college. And I seemed to be the only person that kept a calm head. And I thought to myself, maybe this seems like something I might do. I actually come from a really small town and didn't know any doctors growing up. So it was definitely kind of all new to me. And I actually, when I went to medical school, I didn't even know what I was getting into. So yeah. And then kind of how I got into orthopedics actually was blackmail. So my wonderful friend and mentor, Ned Schwenker, who is just an incredible humanitarian, had done a lot of international aid work. And I had done international aid work, so he got assigned as my mentor. And when I met him, I didn't even know what an orthopedic surgeon was. He asked me what my interests were, and I told him, and he was like, well, I think you should go to the orthopedic interest group meeting and find out about this field. And I was like, well, okay, but I'm not sure I'm interested in it. And when I got there, he actually nominated me to be president. And since he was the group's advisor, they voted me in as president. So I was locked in to learning about orthopedics for a year. It was great. So
captured audience there.
He totally did. And he's apparently done this a few times, and I'm the only time he got it right. So
well, that's a fantastic origin story for sure.
Yeah. I've never looked back. It's been just a wonderful, wonderful path, and he is still a friend and mentor to this day.
Okay, excellent. Now I know you and correct me if I'm wrong, but you went to UC Berkeley. You had your undergraduate degrees were double degree psychology and molecular cell biology. Did that influence you at that time into pursuing medicine specifically, or that was just kind of the general path for you?
I've always loved science. Even from when I was a little kid, I used my microscope so much I broke it. So I've always loved science, and I like answers. So what's one of my biggest struggles in life is when we don't know why something is. And so, I knew that medicine seemed like a good concept, and so did research. And as I was kind of going through college, that was kind of my direction. And I loved the brain-body connection. And so that's part of why that double degree, because I actually, within molecular cellular biology, I actually focused on neurobiology specifically. So, and within psychology, I did biopsychology. So I kind of got the two halves of that interaction. And actually it was a really cool combination. And I continue to use some of that stuff now with our patients.
So it gave you a really good foundation.
Yeah.
Were you always interested in pediatrics, or was that something that you found much more of a calling later on?
Again, well, thank Dr. Schwenker for that, because in that first meeting where he, blackmailed me, he also asked me if I, how I felt about kids. And I said, well, I don't like seeing kids in pain. And he said, well, you know what that tells me? And I said, I don't know, what does it tell you? And he said that you like kids more than adults. And I thought to myself, well, maybe that's true. It's just, I think the resiliency of children is incredible. They just want to get better. They want to play. You'll see a kid with a broken arm running around, playing tag, doing all this stuff, but holding their little arm close to their body. But they just find a way. And I think that tenacious spirit just is so wonderful. And then as parents, you just want the best for your kids, and you will do more for your children than you will for yourself. And I just think that when you understand parents and their motivation and their desire to just care for their children, it just, to me, it was a no-brainer, and it just, it makes it better every day. The interactions with the whole family and being able to follow kids throughout their path. I work a lot with early onset scoliosis, and so to see a kid as a baby and watch them grow up and develop a personality is really cool.
Super rewarding, I can't imagine. Excellent.
Yeah.
Now, you've been at Shriners Portland for about 5 years now, right? What kind of drew you to Shriners, and what keeps you there?
Yeah, so it's a lot of things. One, it's the incredible pathology. So, you know, I see kids that have rare diseases. You know, one of my patients in my practice, there are like 10 known cases in the US. And in the beginning, it was like every day I was learning about some sort of new disease, new diagnosis, and really expanding my horizon so quickly. And I think that those families are so passionate, and they're really want to learn, and they're excited to share their story, and they teach me. And so I love those families. And I think that you get that unique opportunity at a Shriners Hospital, because I mean, I have kids that come and see me from Russia, Alaska, Canada, you know, Africa. I mean, they come from everywhere. And I don't think you necessarily get that opportunity in other places. And then the Shriners Hospital in Portland, actually in particular, has an incredibly strong basic science research department. So, interestingly enough, actually, the guy that identified the gene for Marfan's is there. A lot of the early work with achondroplasia and Marfan's has all been done in Portland, and they've really set the foundation for a lot of the stuff that we do elsewhere. And it's really, really cool to work with these incredible researchers. And so to me, I could do rare disease, I could do research, and Shriners in general really supports a good family life. So my kids still know my name, and we're still good friends every day. So.
Is it, well, it seems, I didn't really know that about Portland at all in terms of the strong science basic background. Is Shriners, the different centers, kind of set up that way in terms of they all have specific strengths?
Yeah, you know, so it depends. Some of the Shriners do have basic science and some of them don't. So that's not across all of them, but research has been something that's very important. So you'll see that a lot of them, even if they don't have basic science, will have a gait lab or other sort of a strong clinical program. And then within it, so I think people have heard about getting NIH grants and things like that. There's actually a similar system within the Shriners system that actually funds a ton of the burns research that's done throughout the country, and actually funded a lot of the early work on vertebral body tethering. So it's very, very cool because you can have kind of a government level grant, but at your smaller institution. And that's kind of what also has funded a lot of my research. And so, yeah.
No, it's interesting that you brought that up, because in talking with Dr. Sam Danny at Philadelphia Shriners, he was saying that it would have been extremely difficult to do any of the FDA approval for VBT without Shriners support. So it's just, you know, I really didn't know much about Shriners before, but the more and more I learn, I just can't really believe it's an actual existing organization.
Yeah, I think it's such an incredible and unique institution. So, and the history with Peds Ortho, so they actually trained a huge number of the pediatric orthopedic surgeons in this country and throughout the world, just because they've had that strong dedication to education. And they really do encourage you to travel and to go and present at conferences. And in our whole structure, as a medical staff, it encourages that. Whereas I think a lot of other institutions are actually limited in the amount that you can do. So I think that's where you get people like Dr. Samdani within the system, because he's such an incredible star. He could work anywhere, but they support us so much that I don't think he, and I know I have zero desire to ever kind of go anywhere else, because again, they treat us so well, and they support all of these ideas. And let us, you know, kind of grow both intellectually and then also, you know, as a physician and as a surgeon. So
that says a lot in terms of, you know, you're not looking for other opportunities at all. You have everything where you're at. Okay.
Well, and we also are all good partners. Like everybody takes care of each other because there's no competition. Everybody kind of has their own role and their own niche, and they're encouraged to pursue their passion. And so then I think everybody feels valued. And I think when you can have everybody feel valued, that's huge because you just promote a positive culture, and then people succeed more, if that makes sense.
Oh, it does. And let's segue into one of your passions, which is research.
Yeah.
And you were speaking before about how it's very interesting and rewarding to see how, especially with early onset scoliosis, and as your patients grow, right, through the years, you see the impact that your work has on them, right? And you have to plan ahead. You almost have to try and predict the future outcomes. So difficult, right? And that's why I wanted to bring up, segue into your White Cloud Award for Best Basic Science Paper last year from the Scoliosis Research Society. I'll just read the title. It's a mouthful, but I think 10 people in the world can understand it. But anyway, it's correlation of Collagen-X biomarker, CXM, with peak height velocity radiographic measures of growth in idiopathic scoliosis. Now, this is, to me, a total game changer in terms of pediatric cases, and very much allows you to much more accurately predict the future in terms of, what stage of maturity the individual is at. Can you talk a little bit about why you were interested in that research and how things started off at the beginning?
Yes, yeah, totally. So we'll talk a little bit about the basics of this, and then what we'll do is kind of talk about the path of the biomarker, if that makes sense. Absolutely. So, you mentioned it, that we can't predict the future. There's no crystal ball. And so, when we think about growth, the way that we currently do it is we base it on the average person. And that doesn't work when you're taking care of an individual, right? And so if you go based on the average person, you can't tell, but I'm pretty tall. I'm 5'9". And when they predicted how tall I would be, they said I was going to be 5'2". I was a late bloomer. I started high school at 4'11", and I grew up until college. I am not like other people. I have kids that come see me and they're done growing at 11. And with scoliosis, we know curves get worse when we're growing rapidly. And so we're always trying to find a way to predict that. And the problem is that the x-rays, again, they give you an average. And what they're doing is they're looking at skeletal maturity. So skeletal maturity basically says, I'm going to grow for maybe another year. But it doesn't tell you I'm going to be tall. It doesn't tell you I'm going to be short. There's a difference between that and what we call growth potential. Growth potential is I'm going to be tall or short, if that makes sense. And so as surgeons, what we really need to know about is growth potential, and as physicians, that's what we need to know about. That's really what matters. Skeletal maturity actually ultimately doesn't matter at all. If you're only going to grow an inch in 4 years, that doesn't matter. But if you're going to grow 10 inches in 1 year, that totally, totally matters. And it will change the way we do everything. So it'll change the way we take care of scoliosis. So everybody knows the big problem with tethers right now is predicting how much more you're going to grow. You can overcorrect or undercorrect or get it right on the money. For bracing, it's the same thing. Like, how long do I even brace somebody? We don't know. And it's also the case for fracture. So if you break your arm, I can leave it a little bit crooked if you're going to straighten it out. But if you're not going to grow a bunch, I can't do that. So this will make a difference in terms of how we take care of fractures. It'll make a difference in terms of scoliosis. Kids with bowed legs, it makes a difference there. So everything we've been doing thus far is based on x-rays. People in the past tried to look at hormones. And if you think about it, teenagers are a ball of hormones and they change hourly. They change hourly adults. So that was actually not a good way to look at it at all. Hormones were not helpful. So people had kind of given up on any kind of biological way to check how much growth you have left. That is, except for a couple of my partners. So back in the early 80s, they looked at the growth plate. And what they saw was that in the growth plate, so that's how bones get longer. That the way that bones got longer was they first made soft bone, because you could make that fast. And then that soft bone was turned into hard bone. And it does it through a particular type of collagen called collagen-10 or collagen-X. And so that particular type of collagen is only found when we turn soft bone into hard bone. And I think that makes sense to everybody, right? That you can make something soft fast, but something hard probably needs more structure and more time. So the cool thing was that they first identified that. And that was, again, it was back in the 80s, but they didn't have the technology to be able to assess that in the blood in a meaningful way. And the reason is that they had to, if you were going to do that, you had to do it immediately. And that's not helpful for any kind of lab or any kind of clinical application. So it was actually only about 5 years ago that there was a change in some of the technology. And when they did it, it became a lot more sensitive. And so instead of having to process the specimen right away, they could actually do it 10 years later. So what happened was that we knew that this marker would tell us about how quickly people were growing. And that's because when you turn that soft bone into hard bone, that collagen is actually released into your blood. So they could measure your blood. They actually could even measure your urine. It's just not as accurate in urine. And they could do it really easily. And so they started a project working with Bill Gates, actually. And they wanted to look at kids in Africa who were starving and what happened if we instituted these feeding programs and these agricultural programs. And what they found was that their collagen levels went up before you could see their height change. And when they saw this, they realized that it was an instantaneous measure of how quick people were growing. And so then they needed to prove it. Yeah. Yeah, so they needed to prove it. And that happened to be the moment that I got to Portland. And so they had talked to some of my partners, and my partners were like, oh man, that sounds like too much work. And I have this problem where I always underestimate how much work it's going to be. And so when they talked to me, I got really excited. And I talked to them about what we could do to use this to validate it as an instantaneous measure of growth. And we wrote a lot of really bad grants, and one of them got accepted. And actually POSNA gave us some money, and I used that to do a pilot study that proved that they were right. And then I wrote a better grant to the Shriner system, and they gave me a lot of money. They believed in me. They gave me a lot of money. And now we're a 4-year multi-center study with Dr. Samdani and Dr. Jim Sanders, who happens to be one of the world's experts on growth, and Dr. Bob Cho, who's and Dr. Selena Poon down in LA, and then also Dr. Talwalker, who is in Lexington, who also happens to have done a lot of work on growth. So it's really cool because we're now proving this in different ethnic populations. We're proving it in boys and girls. And it's just showing us that it's going to tell us if somebody's an early bloomer or a late bloomer. It's telling us if you're going to be tall or short, because the last thing you want to do is be an 11-year-old girl that's an early bloomer wearing a brace when you're 13 or 14, but you're done growing and you've been done growing, but somebody's treating you like the average. Mm-hmm. And equally bad is being, that 15, as like a 17-year-old girl that's still growing, but they took you out of your brace when you were 15 and your curve's just getting crazy. I mean, you want to find a way to take care of each individual person. And the super cool thing, and actually I just looked at fresh data this morning, so I'm particularly excited, is that it's absolutely doing that. It's more accurate than any X-ray technique. So that we've looked at all the different measures of maturity, and it correlates with height better than all of those. And actually for cessation of growth. So far, we've not been able to find any radiographic parameter that actually correlates with when you're done growing. So we actually don't know when to take a brace off a kid. And that matters. If you've got, a moderately sized curve, the last thing you want is for that curve to get worse after like years of effort of wearing a brace, because you took it off a few months too early. So it's pretty cool.
Oh, it's super cool. I think it was meant to be in terms of just the sequence of events and you being at Shriners and the work you put in for the grants, and then Shriners backing you as well. It was meant to be, right?
Well, I have felt incredibly supported, and they're all really excited about it. And I think also just kind of fated that I happened to meet Jim Sanders shortly before all this. And also recent president of SRS, Paul Swanseller. He was actually the one who saw the grant, the initial POSNA grant, and he was like, you need to fund this. And he saw through my bad grantsmanship. I was a terrible grant, and he saw the potential. He met me, and I was a young pup. I was just fresh out of training, and I don't know what he saw, but he saw the potential, the twinkle in my eye or something, and he funded it. And I really think that if he hadn't have done this, it would have taken a lot longer to happen. So it's pretty cool stuff.
Very. Now you've been working on it for 4 years, and you published the study last year.
Yeah.
How much further? I assume you're going to be expanding your database for greater accuracy and going into different ethnicities and to different genders, of course. When do you think it's going to be able to be rolled out as an actual working, process technique?
Yeah. So great question. I will say that COVID has put a damper on so many things. But we actually did just add another site just very recently. The LA or Pasadena Shrine is actually going to be joining us, and that's going to add a lot of ethnic diversity, which is great. We're working on the process of FDA certification. And so basically what the first thing you have to do is you actually have to get regulators to come in. They have to look at your lab. They have to make sure that your freezer temperature is exactly right. They have to make sure that all of these things meet really specific processes. And then we actually have to collect the data again, so that way we can prove it to them. And that's going to be a multi-year process, but we it's going down that road. So the first thing that we had to do was prove to everybody that this was worth that process, because it's actually a pretty expensive process. So we've done that, which is great. And now we have to go and redo it all over again and get that data and get that through the FDA. And then once that's through the FDA, the good thing is it's actually considered a low risk. So it's a little bit of a faster protocol through the FDA, but I would suspect a few more years, and then this will be available to people all over the place. And what's so cool is that the way that we do this test is a finger stick. So you might have seen people with diabetes and they just do a little poke on their finger. So same thing, it's just a little poke on your finger, and you put a little drop of blood on a card, and you can literally mail us that card from Mongolia. You can mail it from sub-Saharan Africa. We have processed specimens that are 10 years old from other countries, and it's still accurate.
That sounds too good to be true.
Yeah, I mean, we said there's a lot left to do in this. There's a lot of work, and it's going to be, anytime you change practice, it's a lot. But I think it is very cool, and I think it's definitely, as you said, it's going to be a game changer, because it's going to allow me to treat you, right, or your son or your daughter, and not like, the average kid. There is no actual average person. So
true. And well, you've answered my question, because I was going to ask you, can you just do a simple blood test? Can your family doctor just run it? But just a pinprick on a piece of paper and mailing it in, that's ridiculous in terms of, what does something like that, what's something like that cost in terms of real?
Well, so as a Shriners Hospital, we are a not-for-profit. So for us right now, we don't charge anything for it, because everybody is part of the study, and ultimately we will never charge anything for it. But probably what will happen at some point is that they'll like lease it or sell it to somebody who would be able to do this on a larger scale, because that's just not what we do. We're in it for the science. We're in it for kind of the betterment of humanity. And as a not-for-profit, we're not going to be, going down that road. So I can't tell you what it'll ultimately cost, because that'll probably depend upon who commercializes it. But right now, what I can say is that, it's pretty exciting stuff. And, I think that hopefully it'll be readily available to anybody.
Excellent. Now, just for the viewers, when you get that blood test taken, right, and you get the results back, what does that tell you at that specific time in terms of real time? Does it tells you the maturity? Does it tell you how tall you're going to be in terms of in the future? Can you go over that? Okay.
Totally. That's a fantastic question. So that is one of the limitations. So what it'll tell you is, it'll give you a number. And what we know is that if that number is below 5, then you're basically done growing. Okay. So that's a really clear cutoff for us, that there's no significant meaningful growth. And for example, if you're in a brace, perfect for taking off that brace. You're good to go, you're done. Other numbers are a little less meaningful in that you probably want to do it more than once. So a lot of times when we talk about, say, either doing a VBT or does somebody have too much growth for a VBT, and do they need, like, say, a magic rod or something like that? For those people, what it would probably be is a couple of tests separated by maybe a month or 2. And then what we can do is you can see the trend. Are you going up, which means you're still growing? Are you going down? There are certain numbers that would be useful on their own. So there are some kids that are going to be really tall and their numbers are through the roof. And so then you can be like, whoa, that number is way too high. And I think what we're doing with Dr. Sundani, and including some of his tether patients and hopefully the future, because actually this is being written into a grant with Zimmer. And so, potentially we'll be able to dial that down. Is I suspect at some point we're actually going to be able to have a number or a range of numbers that are going to tell us the ideal time for, say, a magic rod, or at the very least, what it'll be able to do is say, hey, this kid's got more growth, leave a little more slack in their tether, or rather, sorry, for the tether, not the magic rod, but this kid's got a little more growth, leave a little more slack. This kid's got a little less, tighten it up a little bit more. And then maybe the number's just too high and you say, hey, they need a magic rod or they need a traditional growing rod.
So it won't specifically tell you, if you're going through a growth spurt and I get the test done a month apart and I'm like 5 feet, it won't be able to tell me specifically I'm going to be 5'5" or 5'3" or 6 foot, that type of thing.
So not quite yet. What I can tell you is that we can look at, and now I'm getting super technical, the area under the curve. So basically, if you look at a certain amount of numbers and you look at how much is underneath that, then what that does is that will tell you roughly how tall you'll be. So, I can see that, in general, like if you're 30, if you ever hit the number 30, you're tall, and short people really, like, they typically stay in the teens. So I can definitely distinguish tall and short. And I think that when we have a lot more data, and we have, like I said, a couple of time points for an individual, then you would be able to give them a better idea as to how tall they'll be.
Okay. If we kind of look at the conventional radiographic techniques for looking at skeletal maturity, tri-radiate cartilage, Sanders score, Risser classification, how much more accurate is this test than that if you were going to try and quantify it or give a comparison?
Yeah, so, I think that there's a couple of things where, one, those don't distinguish at all between, say, tall and short or early bloomer or late bloomer. They, again, just give you a rough idea of the total amount of time somebody's got left to grow. So, I don't think, again, this is what we're doing isn't perfect, but it's one step or 2 steps kind of beyond that, because it does give you that additional granularity. Okay.
Now, if we jump a little bit to vertebral body tethering, and if we look at true VBT in terms of using the use of bone growth modulation, in terms of trying to straighten the curve or grow out the curve a little bit more, it seems that most of the surgeons I've talked to will tether from, for a very severe curve from maybe a Sanders 2, and at the later stages, maybe 4 or 5, depending on the amount of flexibility remaining. With this particular test, will that be able to dial that down even much more?
Yeah, I think it will. And one of the things that like really strikes me is I had 3 standard stage 5 kiddos that I tethered in a short period of time, you know, and one of those young ladies grew 6 centimeters in 6 months. She had 2 very tall parents and she overcorrected. She's my only patient that overcorrected. I left slack in that tether. I was like, you know, I know she's going to grow, and she still managed to do it. I had one kid that grew 2 centimeters in 6 months, and she was perfect. It was absolute. I mean, like, it's a dream. And then the third kid who actually somehow lost a centimeter. Like, I don't even know how she got shorter, but she got shorter and she didn't correct at all. And so what I dialed in on the table was where she was, and they're all now this is about 3.5 years later, they're all doing great. But, you know, that was as somebody who's a little bit of a perfectionist, that was something that was a challenge for me to not be able to predict that. And so this is actually something where I would have been able to have a better ability to predict the difference. I could have seen that one girl, her numbers would have been real low. It would have told me that either I needed to get her a lot straighter on the table, or maybe a tether wasn't going to be the right thing because maybe she didn't have the ability to remodel those bones. It would have told me that the girl that was going to grow a lot, I probably would have seen her numbers were through the roof, and I would have either waited a little while longer so that it could have been more predictable, or left even more slack in there, you know? And so again, I think it would have refined my decision-making for those 3 kiddos. And I think we see that across the board. There, again, you know, there's a standard stage 2 kid who's going to grow 2 inches. And there's that, you know, like I said, my patient who was a 5, and, you know, she grew 3 inches in those 6 months, and then another 2 inches later. Right. So, you know, that's 6 centimeters, 3 inches. So yeah, I think it would refine our decision-making a lot. And I think it would be very, very helpful. Right now, we kind of use the skeletal maturity, the kid's height, and then the parent's height, and kind of guess. And I think this will make that guess more accurate.
Okay. Now, question, and no one's listening to this at all, so you can tell me the truth. Are you kind of, I'm sure you're testing all of your patients as part of the study anyway, right? Are you kind of using that right now as maybe a hint to their growth potential and how you're addressing your tethers? You can't.
No, I'm actually not. So so one of the most important, and you can share this with everybody. So to me, I believe in this, but I've also seen people believe in things to the point where it clouds their thinking and their reason. And so one of the things that I do, and for the past 5 years, is I've completely blinded myself to their biomarker. And I think that's so important, because what if I'm wrong? This has so much potential to change the way that we're doing things. But, you know, you think about like Theranos, you think about like all of these biologics that were like useless. I would never want to make a decision based on something that we haven't proven. Now, the cool thing is that 4 years later, it looks like I'm totally right. And again, the data this morning was just absolutely spectacular. But until I really have that evidence, I'm not making any decision making. And at this stage, what we're starting to do is we're going through and doing a really detailed analysis, looking at, like, say, when did curves get worse? What did curves actually get worse when kids were still growing, or did they continue to get worse when they were done growing? Because, like, for example, right now, we don't know the answer to that. We don't know if the reason why, so there's a few studies that showed that if you stop a brace based on your Richter score, 25% of people get worse. If you stop it based on Sanders score, about 20% will get worse. And that there's actually even more that are undertreated. And so what the problem is that we don't actually know if that's because they weren't done growing, or if it's because there's some recoil of the curve, right? You took off the brace, it took a little while for it to relax back to where it wanted to go. With this study, because we're taking such detailed height measurements and length measurements, and the biomarker and the x-rays, we're actually going to know if it was that they were still growing or if it was recoil of the spine. So we'll answer that question. Once we got that question answered, then I'll be able to use it or not use it.
Well, first of all, I'm glad I asked that question because it shows me, you're a true scientist, and and you don't want any kind of distractions or anything clouding your results or your particular technique right now. That's pretty interesting, and I love the fact that you're actually running that study, because I've always wondered the same. When braces come off, is the recoil also, is it due to lack of physio or rehab to strengthen the muscles? Because you're wearing a brace so many hours a day, there's got to be atrophy, right? So what is it that's actually causing the rebound effect? So many questions.
No, you're so right. And so we actually try to get our kids into physical therapy or doing core exercises as they're weaning out. So that way, that wouldn't necessarily contribute, because I think you're absolutely right. We're not accounting for all of the different factors. And, honestly, I think it's just a matter of like judgment. I mean, I'm a mom. I would never want anybody to do something on my kids that they didn't know 100%, right? Or at least as a fellow physician, right? It's more like maybe 95%. We don't know anything for sure. But I really want that level of certainty. I don't want my passion for the subject to cloud my judgment. So.
Okay. Now, if we go back a little bit to your history with vertebral body tethering, when was your first exposure to that? And when did you start your first surgery, that type of thing?
Yeah, so it actually started with anterior fusions. When I got to Portland, actually two of my partners, Dr. Krivik and Dr. D'Amato, and people might know Dr. D'Amato because he actually invented the Providence brace. They were two really phenomenal surgeons who did a lot of anterior work and were continuing to do a lot of anterior surgery. So they actually taught me how to do this. So I learned as an attending rather than in my training. And I thought it was really phenomenal. And it was about that time that I went to a Schreiner's spine surgeon study group meeting, and I met Dr. Samdani, who, as you know, is literally one of the nicest human beings on the planet. And he just kind of took me under his wing, and he was really kind, and they were talking about vertebral body tethering, and it was really intriguing. And so he had invited me to Philadelphia. So actually I went out there and I learned how to do it from him. And, for people that are maybe not familiar with the technique, it's essentially like an easier version of an anterior fusion. It's the same approach, it's the same instrumentation, but you just don't have to take out the discs. So it's one less step. Obviously there's subtleties in tensioning the tether, but it's a very, very similar procedure. And so the cool thing was that I'd had a lot of the skill set, and then I was able to really learn some of the subtleties and the way that he was doing things. I still waited. So I learned from him. And then because I'm not somebody to jump on a bandwagon, I'm pretty cautious about things. I wanted to see more evidence. So, I was waiting for some of the publications to come out from Dr. Samdani and Dr. Newton. And I was able to become friends with Dr. Newton as well, and really learning from them and talking with them offline about this and who it's right in and who it's not. I then had, a series of patients that came in who really met that criteria. And that's when I kind of started doing it, and I saw how well they did. And that's really what kind of started my journey. But it was actually a very, very cautious, like dipping the toe in the water, and then, slowly kind of going forward as I saw it working in other people's hands.
Very good. Because I know with the minimally invasive thoracoscopic approach, it's a skill set that actually only a few pediatric surgeons actually have. Mm-hmm. And from just talking to surgeons, they estimate maybe it's less than 5% of pediatric surgeons know that particular technique. So once again, it's kind of interesting to see the sequence of events in your life and your career that's taking you from one place to another. Pretty interesting to me anyway. So that's fascinating. Now, what what do you remember what year your first tether was? How many tethers you've done or VBTs you've done?
Oh man, I don't know because between VBTs and anterior fusions, I'm doing at least a couple of anterior procedures every month. But I have been doing anterior fusions for about 5 years, and then the VBTs for probably about 3.5.
Okay. Can you talk about your perfect parameters for VBT?
Yeah, so I think that first it actually comes down to the family's personality. So, and that is not something that fits in with the technical criteria, right? I think that, especially if we're talking about a thoracic procedure, the thoracoscopic nature is awesome. The recovery is faster, which is great. But, we define a successful outcome with VBT as a curve less than 35 degrees when you're done growing and the tether's broken. Well, that means that there's a fair amount of uncertainty, right? Every time you come back in to see me, how much straighter did you get? And did the tether break? There's some uncertainty for the family. And I think that there's some families that they don't want uncertainty. I think families that are more type A, oftentimes engineers, that where precision is really, in a defined outcome. And so the first thing I want to do is kind of feel out what their personality is. Because I think that for those families, that uncertainty actually creates a lot of emotional turmoil and angst. And that's just not the right option for them. And we're still making this procedure better. Even in the best hands, the complication rate is higher than it is for fusion. And when I say complication, I mean the likelihood of a second procedure. We just had Dr. Sukin Shah gave a wonderful award-winning presentation at SRS that talked about their prospective study looking at fusions and the likelihood of a second procedure. And that number is just still a little bit lower than a tether. So I need to know that they're comfortable with the different outcomes and that motion preservation is really going to be important in that kid. Then again, I've actually just been doing a deep dive into the database with the pediatric spine study group. And actually we're doing a big study right now looking at kind of the long-term outcomes in our VBT patients. And, some of it is dependent upon your lanky type and your curve type. Some of it is dependent upon the flexibility. So certainly those curves that are more rigid, if you're not bending down under, say, 35 degrees, you're just not going to get as ideal of an outcome. Now, in some families, if you're an ultra competitive athlete and you just need to buy 2 more years where you control that curve, maybe you're okay with that. Maybe you're okay with the fact that you're going to need a fusion down the road. And that's fine if you understand that. And then the other thing is just the overall size of the curve. Really looking at this, the bigger curves just don't tend to have as successful of an outcome. And what we found was on average about a 44-45% correction in the size of the curve at the most recent follow-up. So if you're starting with a 70-degree curve, and I'm going to get you about 44 or 45%, I'm probably only going to get you to about, 30, the upper 30s or maybe 40 degrees. And is that a desirable outcome? It depends on the kid and it depends on the family.
Okay. A question I like to ask surgeons is, it's very difficult to predict remaining growth modulation. Hopefully, obviously your test is going to change that, which is awesome. A question I have though is that it seems that surgeons tend to aim for hopefully around 50% correction on the first standing X-ray, and over the next year, 2 or 3, looking for maybe 20%, 25% max, right? I would say on average. If that's the case, I know there's a chance or the risk of overcorrection. What stops surgeons from correcting more than 50%, maybe 60, 65, if they know that it's not going to get to 100? If you know.
Yeah, so I think that's actually not so much the surgeon and the technique as the patient. So I think that's about that curve rigidity and that curve size. So again, I've been looking at this huge database, and actually just this morning, looking at this huge database, and we'll actually be hopefully submitting this to present at SRS next year. But basically, what we really find is that the average correction at over 2 years was about 44 to 45%. And that's the total. And so what was really interesting was that actually the first X-ray was very similar. It was 43%. So even though we actually hope that kids will continue to correct, many of them don't. So the challenge here is that actually, as you said, some of them overcorrect. Some of them do keep correcting. But then when the tether breaks, they lose a little bit. So I think that longer term follow-up reflects actually that tether breakage and that little bit of the correction that you lose. So again, I don't think we've defined yet how much more you're going to get. And I think that, if your curve is more rigid, you're just not going to get quite as much because it's you can't tension the tether that much yet. But overall, I really do see that there's some kids that they get it perfect. And some of that's going to be your surgeon. Some certain surgeons just seem to do a little bit better job of getting it perfect. Some of it's obviously the patient and the patient parameters. So if you have a particularly flexible curve, those curves do correct better.
It's a couple follow-up questions because you brought some interesting data there. It'll be interesting to see that research around the 45%, 45%
Yeah.
correction. And that's a couple of years out or 3 years out?
So it was a minimum of 2 years. So all of those kids had followed for at least that long. And I'd say about half of them had had their tether rupture. So some of those curves, as you said, had continued to get better. And then once the tether ruptured, they'd lost a little bit. And so that's probably why on average, we weren't seeing more correction down the road because they lost a little bit when that tether does rupture. But for some, not every kid does. And I think those are the ones that remodeled, right? Mm-hmm. If bones reshaped themselves appropriately, then they didn't. Also, because there's longer term follow-up, these are kids with the original tether in, which were more likely to rupture earlier because of the technology has changed, or at least theoretically.
Now, does this end support to the argument that, well, maybe tethers shouldn't be left as loose and should be a little bit more tighter at the beginning and maybe looking for, 60% correction on first standing, 70%?
Yeah, so oh God, and again, I think if we had the answer to your question, that we'd be so much more successful. I'm hoping that with this study, and then also Dr. Kenneth Chung has been working on a similar one as well, and we've been collaborating. But I think there's two things. One, we don't have a good grasp on who's going to overcorrect. And overcorrection is, I think, worse than, say, undercorrecting by, say, 10 or 15 degrees. I would much rather somebody had, say, a 20-degree curve when we're all said and done, than they overcorrected and I had to do a second procedure and take that tether out. It also depends upon where in your body is. So those thoracolumbar curves, if they overcorrect, you kind of wind up leaning off to the side, and that's really not good. Versus if it's in the thoracic spine and they overcorrect, well, you have good balance below, and so those don't tend to cause as much of a problem. So some of it's going to depend upon where you are in the spine, and whether or not you can tolerate that overcorrection. I don't think you can tolerate it as well when it's a curve lower down versus the curves that are higher up.
Okay. Now, Dr. Welborn, since we're on this topic, in terms of, there are some surgeons who are kind of pushing the boundary in terms of trying to increase flexibility of curves and even going into a little bit more mature spines. So you will have the spectrum of surgeons' opinions on disc release. On one end is, there is some research indicating that even a single needle puncture can result in much threefold increase in degeneration over time, right? And you have the other spectrum that says, well, the disc has already been compromised, especially at the apex, and that they would release the disc in terms of freeing up more mobility. Where do you sit on that spectrum?
Yeah, so I can't wait to learn more about it. I think that time is going to give us the answer. I think for me, I try to respect the disc. And so I don't do disc releases. I've unfortunately seen a few kids who had them and they actually came in and that area had clearly fused. You could see, osteophytes or bone bridging the levels actually on the x-ray. And so, I think that in my hands, it's not what I'm doing right now, but I also think that there's so many things that we're learning about and we're learning about the ways to do them. And so, maybe that's also an evolving technique that we might do down the road, but we haven't perfected it yet. So I stand in hopefully the land of Switzerland on this one, where I'm going to stay a little bit neutral. I'm currently not performing it. And again, I think that you have to understand what that particular family's goals are. I work with a lot of elite athletes, and if somebody comes into me and they've got a bigger curve and they're like, Doc, I'm a golfer or I'm a baseball player, all I do is bend and twist. I need to bend and twist for, a few more years. I'm cool with that, and, maybe needing something else later. I'd be like, okay, you've explained it to me. Your goals and my goals are aligned. But, I think one of the things that's so important is, and what's so great about the Shrine is that I'm not paid or incentivized in any way to operate. And so I really try to have this be a genuine conversation with a family. And I want them to know the pluses and minuses. And I also want them, I want to know what their goals are out of this. And if their goals are reasonable, then that's great. And maybe I would do a disc release in just the right kiddo who had just the right reason for it. But right now, I'm not doing it because to me, I think it probably results in a fusion.
Okay. Do you tether down to the lumbar spine right now as well?
Mm-hmm. Yeah.
And it seems that the greatest potentials for the lumbar spine in terms of you reducing, fusion in that area, because that's where all the mobility is, versus the thoracic spine where there's much less.
I agree.
Are you also doing double tethers to the lumbar spine at this point?
I haven't been. And, so I have a lot of dancers and gymnasts and those are the ones that I've done this in. And they've got that preserved mobility and they're super happy. And it is, I think part of why a lot of surgeons don't do it is that you're right. It's a little more likely to break, which is why some people do the double tether. And then also it's a little bit more invasive because you can't do it purely thoracoscopically. And so, it's a bigger procedure and so maybe some people aren't doing it because of that. For me, because I did so many open procedures, it's something I'm pretty comfortable with. And so I probably do more thoracolumbar tethers than I do thoracic tethers because I do see that as such a huge benefit. To me, and some of the early data that I've seen, it looks like the double tethers are almost as rigid as a rod. And so, I think you lose the benefit of the mobility at that point. So I'm not doing a double tether. Also, because Oregon happens to be a pretty active place. I tend to see a lot of pretty slender kids, and oftentimes their vertebrae are just too small to do a double tether in. So it's kind of a combination of patient factors, and then also, like I said, I think you lose the mobility when you do two.
Fair enough. Now I have a question about activity post tethering. Because I guess logic states that, it's a tether, if you increase the amount of stress on it with post-surgery, that probably would increase the tether breakage rate. I guess you have to weigh that against, what that particular child wants to do in terms of, especially if they're an elite athlete. Can you talk a little bit about your perspective on that?
Yeah, so I let them go back to all activity once I think that the muscle walls have healed. So typically about 6 weeks at that point, I think there should be bone integration into the screws and the muscle walls have healed. And so typically at that point, I lift all restrictions because I'm not trying to get a fusion, right? If I was trying to get a fusion, then I would wait quite a bit longer. Actually, I slowed my fusions down quite a bit. But, and again, one of my early patients was an incredible dancer. You can't imagine more flexibility. And, she bends and gyrates and does all these things. And she had a thoracolumbar tether. And it was about 3 years before I saw a rupture at the very end. And she didn't lose any correction, but I think that was because she had remodeled the bone, So, that is something where I think especially with hopefully the newer tether being a little bit stronger and then having a slightly different locking mechanism, that we won't see some of those earlier ruptures that we did in other kids. And I think it's the bending and the twisting that's going to rupture it. To me, you just don't have as much motion and flexion and extension that you'd likely do it.
Okay. I'd like to ask you just a couple more questions if you have time.
Yeah.
Since you brought up a little bit of maybe a newer tether technology, because, parents are always interested in, is there a new tether coming out? Is there stronger? Can you address, I guess, with Zimmer? That's who you use right now. Can you talk a little bit about that?
Yeah, so part of why I use Zimmer is because it is the only one that's FDA approved. And I feel like if there's an FDA approved option, you kind of got to do that. Also because I trained with Dr. Sundani and, that's what he had used. So there was the original version that was with Dynasys. And then subsequently the FDA approved version is the tether. And so that particular one is slightly different. It has a slightly different set screw, has different tensioning mechanisms, and a slightly different actual tether itself. And so, that was something that they worked with pretty extensively with Dr. Miyanji up in Vancouver and Dr. Sundani, as well as some of the other surgeons. I was actually one of the alpha release surgeons, which was pretty cool. That was something, and the only woman, but that was something that was really cool to be a part of, because it was really about learning that technology. And so I think that is, I think it's definitely better than the original version, which wasn't actually designed for this. I'm not familiar with the Globus one. I haven't worked with that one. And then, I know Stefan Perrant pretty well. I think he's an innovator and he is working on one as well that I understand is kind of cool and got a lot of really next level features to it. And I know that Dr. Noel Larson is also working on developing one as well. So I think that there's several different versions out there. And likely, each one is going to have different things about it that are cool and also kind of take that technology kind of to the next level. And I'm sure that, with Zimmer, that there'll probably be a Tether 2.0 and 3.0 as we learn more about how to do this and how to do it better. And I think ultimately it's about, being better for our patients and understanding, what it is that does make it ruptures, and what it is that will help to make that more successful for them.
Okay. Now, final question. If you look 5, 10, 15 years into the future, what do you see as the future to scoliosis surgery?
Yeah, God, that's such a great question. I really wish I had my crystal ball, but I do think that the biomarker is going to be a big part of it. I think it's going to really personalize our treatment. We do more magic rods than, we're the second largest center for magic rods in the country. We do a lot of early onset scoliosis. And I think one of the things is that, so many kids maybe, around the world didn't need it. Maybe they're 8, but they're just not going to grow that much. And so I think that what we will see is we will see a refinement in our application of each procedure. We will have a much better idea of who is the right candidate for a magic rod, a tether, a fusion. And I think that's the thing that's going to be really cool. I think that Stefan Perrant is doing some really neat stuff with modeling. And actually, he's starting to work on an ability to predict whose curves are going to get worse versus not. And some of that has to do with disc wedging that you can actually see early on. And if you don't have that disc wedging, your curve is probably not going to get worse. So then maybe we never even need to brace that kid, and I'm sure your child was in a brace, right?
Yes.
Was it the worst thing ever for them?
Well, I think it was worse for me. Because as a parent, you're watching him and you're going, oh, you're suffering for him. But he was pretty stoic and he would just get on with it, right? But I know
I like it.
lots of kids just basically get emotionally scarred from it, right?
Right.
Yes.
And, I feel like 80% of kids just kind of tolerate it. Like, it's not great. They definitely rather not be in it. There's like 10% of kids that kind of like it. And then you're right. There's 10% of kids that kind of get scarred, and some of the kids move between groups. But, if we could find a better way to say, you're never going to need this, or target it to the right phase of growth and shorten the duration so that, again, it's not so impactful. I think that would be huge. My sense is that the braces are going to get more minimally invasive, or rather minimal size, if that makes sense. There's some cool stuff that's happening with pressure sensors so that we can actually know that people are wearing it tight enough. Because I had a lovely young lady came in yesterday with her brace and I could spin it on her body. And I'm like, this is not helping you, And so I think a lot of it's going to be making it so that we have a consistent way that we're treating those patients. So the brace is effective if we are using it, shorten the amount of time that kids need these interventions, and then refining who gets what and when. I think that's going to be one of the big things that happens next. Obviously, if we could figure out what the genesis of scoliosis is, what's causing it, and we could turn that back, that would be amazing. But I don't know that we're going to be able to do that. But I do think that we're going to find better and better ways to preserve motion. I think we're going to find better and better ways to improve our outcomes so that each kid gets a better, more ideal outcome by making sure we do the right procedure, the right levels, the right correction, and I think, pedicle screws have only been around since the 90s. And so things have changed so dramatically in the past 20 to 30 years in the way that we take care of these kids, in our understanding of the three-dimensional nature of the spine, in our understanding of how it moves. And I think that'll help a lot.
Great answer. Okay. I just want to say that, can you imagine the potential if you, with your biomarker test, if you can actually tell a child, you just need to wear the brace for a finite time. So they would have that in their brain that, okay, I'm not wearing it for, 2.5 years. I might only need it for 8 months or something like that. Even that's a game changer in itself, right?
It's a huge game changer. And actually that plays off of what Lori Carroll had been doing when she was down at Texas Scottish Rite. So she was one of the first people that did bracing studies with temperature sensors. And she really found the impact of counseling on these families, and that after 6 months, compliance falls way off. Well, if you can give somebody, like you said, a defined time period and say, hey, you wear it for that peak growth is going to be this amount of time, you totally can get buy-in, right? Because they see the light at the end of the tunnel. And I bet then it's also not going to be torture, right? Because they've got parameters. It's not like this, crazy thing, like maybe it's helping, maybe it's not, so yeah.
Yes. Yeah. I also think this is the golden age of scoliosis research. And just talking to all the surgeons and, with Stefan Perron in Montreal and Carl-Eric Aubin, they actually have simulators that are predicting a VBT correction 2 years out, and they can run different permutations. You have the information with you today. It's incredible what that's going to turn out to be, I think. So it's kudos to you and all your colleagues, for sure.
Yeah. Well, and it's just so fun is being able to talk to these people and getting so inspired. I love how everybody's doing it a little bit differently, but I also love that genuine motivation to help people. These names that we're talking about it's a small group of people. It's people that have just dedicated their lives to helping kids being better. And I think that's just so inspiring to be around people who every day just want to do a better job for their patients. None of these are people that are accepting the status quo. They're saying, yeah, what we're doing is good, but can we be better? Can we do a better job for your kid, for my kid, you know, and, you know, I want it to be better, not just tomorrow, but in 5 years, in 10 years, in 20 years. I mean, these are people that are just visionaries, and they're thinking about the long-term, physically, emotionally, socially, everything. And it's a real honor to be a part of that group.
Well said. And from talking to all these surgeons personally, I couldn't agree more. So Dr. Welborn, thank you so much for your time. I really appreciate it. And I can't wait to hear more about your growth biomarker study for sure. And when it's, I'll just have to send in my my blood test myself to see if I have any growth remaining too. Maybe not.
I'll fast track your specimen.
Okay, thank you.
Thanks. Well, thank you so much, Dr. Lee. It was a great honor to be here.
Okay.
Okay.
Oh, it's honor is mine. Thank you. Bye for now.
All right. Thank you so much. All right. Bye.